I'd just take the opportunity to update you a little bit about what's happening in the unit. First of all, staff-wise, because we've got I think we've got well over 2,000 patients now of all types of neuroendocrine tumours, and it's growing and growing, and we're trying to address our clinics. And so I've been looking at ways to do that with our extra staffing. And so you will have met Dr. Dalvinder Mandare, who we appointed as a consultant. He was formerly a research fellow some years ago, and in the last year, Dal has taken over as a consultant in neuroendocrine tumour, and he's a great asset. We have Professor Ashley Grossman, many of you may have heard of as well. So Ashley was a professor of endocrinology, in fact, formerly at St Bartholomew's Hospital, and then went to Oxford. So Ashley had, in fact, just retired from Bart, but lives in London, and he's really good. So I nabbed him and said, "You're not going to retire just yet." And so he's helps out now on our Monday clinic and within our multidisciplinary tumour board meeting, which we hold on a weekly basis as well. So to have someone of his experience and quality as well joining our unit, it helps not only in terms for seeing patients and having his input to see you, but also in our research program as well, because Ashley's got a fountain of knowledge and ideas. So he's a great acquisition. And also we've got a new research nurse, Sarah Chamberlain, who's started with us, and because we've got ever increasing clinical trials as well. And I have to apologise for all the waits that you have in clinic. It is, when I said it before, when I started off this clinic back in 1997, we had, it was 30 patients. And that seemed a lot at that time, and there was when we were there, and just kept on growing and growing. So we never believed that we were going to get to having a unit which I suspect is if not the biggest in the world, is certainly one of the biggest now. And to have sort of over 2,000 patients is fantastic from our point of view in terms of the experience and just all the different nuances that one gets to see related to neuroendocrine tumours, but also in fact we have a database of all our patients, and to be able to follow you all so that we're learning the whole time. So one must never stop learning, and that's why I'm very keen to encourage that we still continue to grow the unit, and to thank the Royal Free Hospital for their support actually in allowing us to grow, particularly in this financial climate. On the research side, there's lots happening in terms of research, and if one looks at the clinical trials, I think we've got clinical trials for all types of neuroendocrine tumour, and if they're not ongoing at the moment, they're in development as well, and that covers from looking at high doses of lanreotide autogel, in going to a 2-weekly formulation or every 2 weeks rather, the high dose instead of every month in pancreatic neuroendocrine tumour patients. We've got new immunotherapy clinical trials for the high-grade neuroendocrine tumours. We have a whole, for lung neuroendocrine tumours, there's a clinical trial on somatostatin analogues, and plenty more actually. We've got the new targeted therapies with the next generation of the lutetium treatments, and even though lutetium is not yet licensed, we're still looking ahead to the next generation. We're doing clinical trials on with those new agents. And actually, so we've got, and lots more in fact. So it's particularly exciting that the drug companies often come to us first of all with their new drugs and see whether or not it's going to be appropriate. And I'm always keen to encourage that. And also, we do assess all our patients actually. So every time at our weekly multidisciplinary tumour board meeting, every case we review, we see if that patient is going to be suitable for a clinical trial. And also every Monday morning before we get to see you, we do an overview. So all the team are there where we go through every single patient that's going to be reviewed on that Monday morning, so that, which is why the clinic starts a little bit late as well, but we started at 8 o'clock. And between 8 and 9 we go through all the patients to make sure we've hopefully got everything, but also actually to see who's appropriate for clinical trials. So we're always assessing for that, and we'll often discuss with you hopefully relevant trials. And you can always ask, is there anything that I should be going for in terms of any clinical trials? We have a large basic science program as well, looking at the cellular level of neuroendocrine tumours. We have a large component run out of the clinical, out of the cancer centre, and our research spans the whole of University College London. And so out of the cancer centre, led by Chrissy Thirlwell and Tim Mayer, looking again at immunotherapy, at genomics and the way the gene changes associated with neuroendocrine tumours. We've just started fairly recently a program looking at in intestinal carcinoids, neuroendocrine tumours, the fibrotic desmoplastic mass effect, which caused a lot of intestinal issues, and no one knows the cause of it, no one knows how to treat it properly, and so we have a program that's addressing that as well, and amongst other basic science programs. And I think that has kept on growing and growing across nuclear medicine imaging, all aspects of neuroendocrine tumour care, and we're putting in a grant for carcinoid heart disease as well, related to patients with carcinoid syndrome with the increased risk of developing carcinoid heart disease. So every aspect of it, I think that we can't stop learning, we should be doing some form of understanding, making sure we understand the basic science of it, and then translating that into clinical trials, looking for the future. We're lucky that over the last number of years we've had great new developments, but originally the carcinoid, the Net Patient Foundation, we called it Living with Carcinoid, and the aim was that our patients should be well and living with their illness, and please God, they should be living for many, many years with it. And so therefore, because of that, one wants to have many treatments, because often, as you know, you go from one treatment to another. And so the more treatment options we have, the better, and I think our clinical program and scientific program are looking to address that, and we collaborate internationally as well to ensure that everyone has access to data. You may have read that NICE approved everolimus recently, so that's now approved not only for pancreatic neuroendocrine tumours, it's also approved for intestinal and lung neuroendocrine tumours. So that's very good. NICE are reviewing the lutetium-177 dotaoctretate therapy. That's the magic bullet targeted therapy. And as you know, it's been a real problem getting funding for that, and it's taken many hours of pen pushing and negotiating, and we've been very fortunate to work closely with the company that manufactures it, and through negotiation, one way or another, have been able to still treat our patients with lutetium therapy, and although there can be some delay related to it, we're still managing to treat our patients. And the good thing is we also have other options though as well. And some of our patients actually are going into the new clinical trials related to the new lutetiums coming out as well. So we're trying as best we can to manage the difficulties of not having a NICE approved drug. I think we hope to have approval by the end of the year, actually, so that's the plan. There's going to be a new drug called telotrestat. Some of you were involved in the clinical trials, which is an oral tablet for the treatment of carcinoid syndrome, particularly related to diarrhea, and I think we'll have that available, all being well, maybe certainly by the summer of next year, if not before. And there's lots of other drugs going through the process. So I think these are exciting times. We never stop, and that's the aim. There's the adage is, if you just plateau out and be happy with what you've got, then you're eventually just going backwards. And so the aim must always be to continue to grow and improve, and that's our ethos in the unit. So without any further ado, and I can see Dominic Yu there, who's our main speaker for tonight, and I don't want to hog his podium, but once again, thank you for your support, thank you for having this support meeting, and also, as I say, your involvement in clinical trials where we're learning from you all the time, but certainly your feedback or anything you want to coordinate through Ash. And then I will introduce Dominic. So Dominic is our now senior interventional radiologist at the Royal Free, and Dominic and I have worked together now for many years, and Dominic's experience in liver, pancreatic, and all sorts of diseases is fantastic, and he's an interventional radiologist, so embolization, cutting off blood supply, to tumours in the liver, to putting in stents, and he does a lot, and he's a particularly skilled, he's artisan at what he does, and a very good diagnostician as well. So it's a great pleasure to introduce Dominic, who's going to be talking about actually many of the new and different interventions that he does for our neuroendocrine tumour patients. So Dominic, thank you very much.
So I'm a radiologist. So radiology is about imaging, so X-rays, ultrasound, CT, MRI, but there is a small subdivision of radiology called interventional radiology, which means that we use imaging to do procedures. So there are more and more things that we do with procedures, and most of these procedures are done through a very small hole. So people talk about keyhole surgery, so laparoscopy and things like that. What I do is like pinhole surgery. I do a lot of things with holes which is no more than 5 or 6 millimeters. So if there's anything you don't understand of terminology and things like that, stop me straight away. If you want to ask about the content, maybe towards the end of the talk, but if you want to ask about a specific thing, saying something that you don't understand at all, stop me straight away, okay? It's very difficult to know how to explain everything. So what do I offer patients with a neuroendocrine tumor? At the very basic level, biopsy. And then we also do procedure to facilitate surgery, especially liver surgery, to take away part of the liver. We do treatment of neuroendocrine tumor itself, especially when it's spread to the liver. And also we can deal with complications that arises from neuroendocrine tumor itself, rather than treating the tumor, but treating the complications. So those are the 4 main things I'm going to talk about. Biopsy. Why do we need to do biopsy? Because, one, we need to know the diagnosis. So if the patient presents with symptoms of bowel symptoms and we do an ultrasound CT scan, we find a tumor within the mesentery, it's quite deep, it's difficult to biopsy, but there are lesions in the liver, then we will tend to biopsy the liver because it's easier to do and probably lower risk. So, but sometimes we already know the diagnosis because we suspect there's a neuroendocrine tumor, we do functional imaging, and I'm sure a lot of you would know about functional imaging because you've had it, and that's pretty specific for neuroendocrine tumor. But still, we do still need to biopsy it because we need to grade the tumor. So we need to know whether it's low grade, intermediate grade, high grade, and something called the proliferative index. If we know how aggressive the tumor is, then we know how aggressive the treatment should be. So even if we know diagnosis, we do tend to biopsy it. And occasionally, when it's low-grade tumor and suddenly changes, suddenly it's advancing quicker than we expect, we might do a second biopsy, see whether it has changed, because sometimes we have seen the changes. So biopsy, probably a lot of you have had that done. Sometimes it's in the liver, sometimes it's lymph nodes, but we can do a lot of different areas. There's something else called venous sampling that we used to do. It's mainly for very small tumors in the pancreas that secretes insulin. And these patients will have sudden surge of insulin, which, as you know, decreases the blood sugar level, and they get in comas all of a sudden, because all of a sudden surge, and then the blood sugar goes so low that they go into coma. And these are very, very small tumors, used to be very, very difficult to see. And when you suspect that, you do some blood tests, and you think, oh, there's insulinoma in somewhere in the pancreas. We can't see it in imaging. And what we used to do, we used to go in and actually do blood sampling from different blood vessels and try to locate which part of the pancreas it comes from. But nowadays it's very unusually done. I haven't done one for 10 years now because now the CT and MR is so much better, and especially functional imaging is so much better that we don't need to do the invasive test anymore. But if we were to do this, we'll probably end up seeing something like this. If we can do it, then that is actually a tumor within the pancreas that's supplied by the blood vessel coming from the spleen, so it's got a splenic artery. So that is a neuroendocrine tumor in the pancreas. Yes?
Could you just explain what you mean by functional imaging?
Functional imaging is nuclear medicine that you use the function of the tumor to help you locate where it is. So the ones that I do, so X-ray, ultrasound, CT and MRI, is what we call anatomical imaging. So you see whether there's a lump somewhere, or whether it's a thickening of the bowel wall, and it tells you where it is, but you don't know about the function of that area. Whereas in nuclear medicine, they use functional. So some of you probably have had a PET scan. So the traditional PET scan uses FDG PET, which uses glucose. So you put radioactivity onto glucose, and whichever part of the body that uses up more glucose lights up. But more specific for neuroendocrine tumor is something called gallium-68 PET, and that is pretty much specific for NET. So that's functional imaging. So it's functioning neuroendocrine tumor will light up. So that's what I mean by functional imaging. And that is very good, and in combination with anatomical imaging is particularly good. So how do I facilitate surgery? So if you have liver metastasis, of liver tumor that's spread into the liver, if it's in a certain part of the liver, you might be able to do liver resection. You take away part of the liver. And that can be done only if what's left behind is big enough. But if what we think, well, what we want to leave behind is called the potential liver remnant, if it's not big enough, then we might need to boost that volume a little bit. So what we do is we make use of the fact that the liver has two blood supplies. The liver has an arterial supply called the hepatic artery, and also has something called the portal vein. The liver is a very unique organ. And the portal vein takes all the blood from the gut and the spleen into the liver. So when we eat, we digest, all the nutrients go into the vein and go into the liver first. The liver gets first pick. And therefore, if you cut off the portal vein supply to part of the liver, all the nutrients go to the other side, and that side will grow more. So if you want to take away the right lobe of the liver, which is normally the bigger lobe, and the left lobe is not big enough, we go in there, we block off the right portal vein. All the nutrients go into the left portal vein, the left lobe will grow bigger, and then after a few weeks, we do another scan, we measure the volumes, and if it's big enough, we can go at it with surgery. So this is an MRI scan. There is a big tumor in the right side of the liver. There is another tumor in what's called segment 4, which is part of the left lobe. So what we want to do is leave behind just this little bit and this bit. And you need about 30% of your current liver volume to be big enough, functionally. That is not big enough. So what we do is I use ultrasound to guide a needle into the portal vein, and I put a wire down, put a catheter down. That draws me a map of where the blood vessels are, and then I go into each branch of the ones I want to block off, and I put in some glue. It is superglue. Medical superglue, but superglue nonetheless. But we give it a little bit of contrast material so I can see it. And you can see now it's almost like a Christmas tree, that all those branches are filled with glue. So this is what we showed you just now. This is a few weeks later. You can see that the portal vein to the left is still patent. The portal vein on the right, there is no contrast in it because that's occluded with a glue. But you can see, even with the naked eye, this got bigger. We measured it was big enough, and that was after the resection, and even got even bigger a few weeks later. So, nice and good. But not all the time does it work effectively. Sometimes the left side is still not big enough. Then what we can do is come back and embolize the hepatic vein, which is the outflow. So the portal vein and the hepatic artery takes blood into the liver, and blood leaves the liver via the hepatic vein that goes into the inferior vena cava and then go into the heart. And we can block that. So once we block the inflow, later on we can block the outflow. So this is one such patient that you can see the glue, but these are two branches of the hepatic vein I want to block off. I go in there, I put in these called plugs, and just block off those. And then when we look at the MRI, again, you can see the vein there is patent. There is a plug in the vein, and again, you can see that that's got bigger. And then if it's, again, we measure the volumes, if it's big enough, surgery will go ahead. And not every case we can boost the volume enough. If it doesn't, we're no worse off than before. But obviously, if we can go out of surgery, all the better. And most of the time we do manage to get there. How about treating the liver metastases radiologically? There are two main ways of doing this. They're called local ablation or intraarterial therapy. So either we treat the tumor directly, or we go via the artery to treat it. So that's the two main difference. What do I mean by that? So local ablation is causing damage to the tumor itself. And this one is chemical ablation. So you put some sort of chemical into it. So ethanol, so you use alcohol, that is at least 98% alcohol, sometimes even 100%. What that does is that once you inject into the tumor, it is so concentrated that it draws all the fluid out of the cells and therefore killing the cells. And that's why when you drink a lot of alcohol, you get dehydrated. But if it's 100% alcohol, it really, really hurts the cells. And you used to use acetic acid as well, which is vinegar. Very, very strong vinegar, mind you. But those are a little bit outdated now. For the past 20 years or so, the king of ablation is something called radiofrequency ablation. You put an electrode into the tumor, and you put pads on the thighs to complete the circuit. You put electricity in, and that causes agitation of the ion, the small particles around the electrode, and then the movement causes heat, so it's a controlled burn. So that is a thermal ablation with heat. Cryoablation is thermal ablation with ice, so you freeze that area. Microablation is again thermal ablation, so it is exactly like the microwave that you have at home, but obviously this is a bit more concentrated and controlled, and you can control the size of burn that you need. But there is a limit as to how big you can go. So with radiofrequency ablation, probably 5 centimeters, probably as big as you can go. Cryoablation, probably about the same, but you can do what's called compound burn. You burn 4 centimeter, 4 centimeter, 4 centimeter in a triangular shape, so you get bigger. So it's like a Venn diagram that you're crossing over and get bigger. But now, if you want to burn bigger, microwave is the one that can burn probably up to about 8 centimeter reliably. But radiofrequency is still king around the world at the moment, although in this country we're slowly but surely moving towards microwave. There are two newer things on the block: high intensity focused ultrasound called HIFU that can also ablate tumors. At the moment, it's not that popular because it takes a long time. To actually ablate a 3 centimeter area, Radiofrequency ablation will probably take about 15 minutes. Microwave for 3 centimeter area will take 2 minutes. HIFU will probably take about 1 hour. So it's not very popular at the moment because it takes time. But it has potential benefits or potential advantages that you don't need to put something into the patient. You can actually put that probe outside the patient and do it. So with patients with clotting abnormalities that tend to bleed, this is a great advantage. Or there's a lot of fluid around the liver that is not good to put needle into the tumor, that is good. But again, it's not very common this current moment in time, but it probably will become more popular with when the time comes down. I'm sure with a bit more advanced technology in the next few years, it won't take an hour anymore. IRE is, again, another new thing that reversible electroporation. What you do is you put electrodes in and use electricity inside, and you don't need the pads. They just put more than one, they just zap between the 2 electrodes. And what that does is that it damages the cell wall without heat. So it doesn't cause damage to neighboring structures. And we've done our first case yesterday. So there are only 3 or 4 other centres at the moment in the UK that's doing this. So we did our first one, and we did it in the pancreas. So watch this space. Hopefully we will be doing more, and the results will get better.
So that would be targeted when you say it.
Yeah. So it's targeted. So we, under imaging, normally CT scan, we put those electrodes to where we want to go. So yesterday we put 4 in the 4 corners of the tumor, and then basically all the electricity just go in between the 4 and crisscrossing, and then it's very localized. And it is something that we hope that is going to help us treat more pancreatic cancers, pancreatic tumors.
Does that destroy the tumour or just damage it?
We are hoping that it will destroy the tumor completely, if it's small enough. I think at the moment, you can't treat everything with it. If it's really big, which currently doesn't have a lot of things that works. But the smaller ones, we're hoping that we can do this instead of surgery, or if they don't want to have surgery for whatever reason, this may be an alternative. But there isn't that much data around the world at the moment. We are always trying to get more data. We are trying to pool our data with the other centres in the UK to actually get more data. The jury is still out at the moment. So if there are other alternatives that we know that works, we will always do that. But if those don't work, then maybe this is one other option currently. So we've talked about radiofrequency. But ablation, because there's sheer number of spread in the liver, when it's in both lobes, surgery doesn't work anymore because they're on both sides and they're just too many or too big for ablation. Then we'll have to go via the intra-arterial route. Remember, we said that the liver has 2 blood supplies, so blocking off the portal vein for the portal vein embolization doesn't really damage the liver that much because it has a second blood supply. And this is the reverse now, we block off the artery. Because the liver tumors that spread to the liver from neuroendocrine tumor almost has 100% of its blood supply from the artery. Whereas normal liver gets about 1/3 of its blood supply from the artery and about 2/3 from the portal vein. As long as the portal vein is still going, you can block off the artery to your heart's content. And we play on this fact when we're treating the neuroendocrine liver metastases. So what can we do? We can just block off the artery, so that's just called transarterial embolization. We can give a little bit of chemo with it as well. They're called chemoembolization. We can do the PRRT, the peptide receptor radionuclide therapy. Normally that's given intravenously because you can go to the whole body and get selectively picked up by the tumor. But if it is only liver disease, we can give it into the artery and then everything just stays in the liver and none of the radiation go anywhere else. And there's another way of doing radiation. It's called selective internal radiation therapy, SIRT, or it's also called radioembolization. And these are very small radioactive beads that we throw into the hepatic artery and get stuck in the vasculature within the tumor, and it irradiates it from the inside. So TAE, so again, we've said this before, no portal vein supply, all of this from the artery, and then we induce ischemia and cell death by blocking the arterial supply. There's no oxygen going to the tumor. And as a result, it will shrink, and more particularly, it will stop the hormonal production. So if you have patients who have hormonal production, giving them especially flushing, this is a very good treatment. And then sometimes we do embolization, the flushing level drops within 24 hours.
Which one is that? Which treatment is that?
This is transarterial embolization. Yeah. So we do an arteriography to make sure the arterial supply to the liver, we know where it is. And then we have to make sure that we know that the portal vein is patent. If the portal vein is not patent, we cannot block off the arterial branches. And then we do it one lobe at a time. We don't do the whole liver. And we have to be very, very careful with patients with carcinoid heart disease. Because carcinoid heart disease, the most commonly involved valve is the one on the right, called the tricuspid valve. And if the tricuspid valve is involved, then there is, whenever the heart contracts, blood comes out again. And that causes congestion to the liver. And then the liver, if you do embolization with in those livers, they don't do well. So we have to be very, very careful. The doctor said that we don't do it, but we have to be very, very gentle with it. So this is a liver MRI again with, these are the tumors. You can see that they are brighter than the surrounding liver. This is the arterial phase because that enhances more because it's got more arterial supply. And there are some neuroendocrine tumors in the liver that don't enhance this as much. Those are the ones that we don't embolize. The more arterial supply it has, the more effective it is because you're only blocking off the arterial supply. So this patient, we did an angiogram. So now I've gone into the femoral artery. I got a catheter up, and that is the hepatic artery supply. You can see the individual tumors on both sides of the liver. What I'll do is I'll go more selectively with a smaller catheter. So this catheter is 1.3 millimeter in diameter, and through that I put a smaller one. I put a smaller one that's 0.9 of a millimeter to get closer to it, and then I put in some very small particles, probably about 45 to 100 microns, so a tenth of a millimeter or smaller, to block off those small blood vessels within the tumor. So before embolization, you can see big tumors on both sides. After I've done the right lobe, you only see the tumor on the left side. So we leave it for 4 weeks. You come back and do the left side, and you can see that I'll block those off again. This is not a cure. This is trying to control, and more importantly, try to improve symptoms of hormonal production. Because life finds a way. I think it was Jurassic Park, somebody said that. Life finds a way that does not kill the metastasis completely. What it does is temporarily halt it, and somehow it will find another blood supply or grow another blood supply. It might shrink, but it will grow again. It does not, this is not a cure. I wish it was, but it isn't. But you can see that at least for the time being, you have stopped all the blood supply to it, and therefore stopped the hormonal production with the symptoms of flushing or other types of hormone that whatever that causes, and sometimes you do good shrinkage, but it will come back at some point. How are we doing for time? I think I've got 25 minutes. I might have used that up already. But there are certain circumstances we can't do, which is if you've got a complete portal vein occlusion, as we said, then you cannot block off the artery, because that becomes the only supply to the liver, and the liver will really, really suffer. When you've got liver insufficiency, it means that the liver function is poor. You can't do it. When there's been previous surgery to the bile ducts, which means that there is air in the bile duct, if you do embolize it, you might get infection. If there's obstruction to the bile ducts, or if you've got carcinoid heart disease. So not everybody can have it, but there are potential complications. Something called post-embolization syndrome, because you've got some dead cells in the body. You might get a low-grade fever, the white cell count might go up, or you might get pain. No surprises there. And normally it's well controlled with analgesia, and normally 1 day or 2 in hospital is enough. Occasionally you might get liver failure from it. That's why we only do 1 lobe at a time. You might get carcinoid crisis because the tumor doesn't like it and it will secrete like mad, and therefore, while we're doing it, the patient will be on an infusion of octreotide. You might get abscess, you might get inadvertent embolization of the gallbladder, and therefore you might get inflammation of the gallbladder. So this is a complication that there's a big tumor that we embolize, that half of the tumor is actually dead. So you can, that solid tumor, that is liquid because it's liquefied, because it's dead tissue, a little bit of gas in there, so it might have got a little bit of infection, but you try to just not put a drain into that, you just treat it with antibiotics, and luckily that settled down. If not, we might have to put a drain in to drain the pus out, but normally antibiotics would do, and that is a complication that we would like to have, in the sense that you've actually done pretty good damage to the tumor. This is the patient that had a bit of pain, the gallbladder didn't look so good, and then a day later we did a CT scan. Actually there's a perforated gallbladder because inadvertently some of the particles went into the gallbladder, and then the wall had actually burst, and then the patient ended up having needed the gallbladder out. But so far in 12 years I've been here, we've only needed 1 of those. We had 1 of those. Okay, so sometimes we give chemo as well as just embolization. And there is a lot of data around as to who to give chemo to, who not to give chemo to. And it boils down to the fact that the patient with liver metastasis are 2 main groups. One is midgut NET, also known as carcinoid, and the other type is pancreatic NET. They behave differently. So I'll just go to the chase, is that in midgut carcinoid, embolization does better than chemoembolization. That is not a great surprise, because midgut carcinoid doesn't actually respond to chemotherapy systemically if you're trying to treat the tumor. Whereas the islet cell, which is the pancreatic, respond better. And therefore, if you want to use chemo, you're better off using it in pancreatic patients rather than midgut carcinoid, because we know that traditionally it doesn't work as well anyway. So why would it work better in the liver? And therefore, why risk the complications or potential downside of chemo when you can just do the embolization? So that's what we do. So for midgut patients, we only do embolization. For pancreatic ones, we will think about it and see what we're trying to achieve. If we're trying to shrink the tumor, we might add chemo. If it's just for hormonal production, trying to control the symptoms, we don't feel that chemo is necessary, we just do the embolization. And therefore you get less complications because there's no chemo involved. So this is a patient that we've given chemo to, and that is the tumor. And chemoembolization, with the chemo, we give a little bit of contrast. It's oil-based called Liparda, that we can see that it's got there, and you can see there's clear shrinkage of the tumor. PRRT, some of you probably had the yttrium of the lutetium, which is the radiopeptide treatment, and most of the time it's given intraarterially, as I said, but if it's liver dominant disease, sometimes we give it directly into the artery. So this is the SIRT therapy, but it's very expensive at the moment. It's not funded. Maybe it's for next time I speak to you when we've got funding that we can talk about this, because there's no funding. We do very little of it. That's probably not relevant currently, although we would like to do a little bit more. Next couple of minutes, I will talk about the complication of NET, what we can do. This is a patient with a big tumor, but maybe previously, because of the biopsy, that is what's called pseudoaneurysm. That is the localized bleed from an artery that is contained at the moment, but it's a time bomb that it can burst, and it's not going to be pretty when really, really bleeds. So we need to do something about it. This patient has a very crooked spine. Didn't make life very easy for us because patient can't really lie still on the bed for a very long time. So we go into the blood vessel and then we try to find it. There it is. That is a pseudoaneurysm. We go get close to it again with that small catheter and very tortuous vessel. You can see that from here. I needed to do several hairpin bends to get to it. And luckily these are 0.9 millimeter ones, are very, very soft. We can get there. And then I put in several coils to block off, and then now you don't see the pseudoaneurysm, so the risk of bleeding is gone. There, you don't see it anymore. There's another patient with lymph nodes obstructing the IVC, the inferior vena cava, which is the main blood vessel that takes blood from the legs back up to the heart. When the lymph nodes obstruct the IVC, your legs get swollen, can be very, very uncomfortable and really restrict your movement. There is the aorta, next to it should be the IVC, but what we don't see it at the moment because it's completely obliterated by this lymph node mass completely surrounding the vessels. And then as a result, the patient also has a lot of free fluid and anatomy called ascites, and the patient is a bit bloated, but more importantly, it's the legs that really, really bother the patient. So I go into the femoral vein around the joint, hip joint here under ultrasound, inject a bit of contrast up. Things are not really going up, things should go straight line up. So they are going via the houses, round the houses, going to the back of the body and go back up. So that is the IVC. Now I've got a wire into it. And you can see that still is not good flow. Everything's going down, going via the smaller vessels. Now I've put in a stent, which is the metal tube that opens up and pushes against the lymph nodes. Now you've got a straight line flow again. You're not filling the A and B roads again. You've got open up the motorway again. So this does not change the course of the disease, does not change the progression of the lymph nodes, but it is very, very, very important to do this for symptomatic relief. So obviously, when we do the procedure, we will explain to the patient that this does not change the course of the disease, but you're much better off having this done, and within a few weeks, the legs became normal again. So it is very important. So sometimes we stent the superior vena cava. Again, sometimes it can be lymph nodes in the chest from bronchial neuroendocrine tumor, and lymph node can really press this on the superior vena cava, and what you get is that you get a swollen face, swollen arms, and it's terrible. When we stent that, sometimes within a day or two, the face will go back to normal, and it's a very, very gratifying thing to do. I'll stop there. Okay, any questions? I can go on for a long time, but we don't just have the time for it. And you'll be sick of my voice in a minute.